Okay, thanks. Yeah, I'm Justin. Thank you guys for being here and to listen about some melanoma updates. Sorry. So I decided to kind of go over some of the important updates in melanoma from abstracts over the last 12 months or so. So I'll do a brief reminder of standard treatment options, and then go over the DREAM-seq trial and the Relativity 047 trial. And then if there's time and if I was adequately caffeinated or something, we'll go on to the Keynote 716 and the Prado trial as well. So briefly to start, is 2 better than 1? So the current standard of care was based on the Checkmate 067 trial, where there's 3 arms, 945 patients were randomized to Nivo versus Nivo plus Ipi or Ipi alone. And this defined the role of the doublet combination therapy in metastatic or advanced melanoma. The progression-free survival for the combination doublet was 11.5 months and 6.9 months in the Nivo alone arm, and were found to be superior when individually compared to Ipi alone. Importantly, this trial didn't compare Nivo versus Nivo plus Ipi, or at least at a pre-specified statistical significance. So these numbers are important to keep in mind, those PFS of 11.5 and 6.9 respectively for the doublet versus singlet Nivo for the abstracts today. However, treatment, as we all know probably in this room, is very toxic, with grade 3 to 4 events seen in nearly 44% in the Nivo alone arm and 69% of the doublet combination, with discontinuations in 5% and 29% of patients respectively due to the side effects. And now we have long-term follow-up of this trial. So this is published of the 6.5-year follow-up. And so this is the bar that we set for first-line treatment of melanoma. There's the doublet combination led to 11.5 months of PFS and 72.1 months of overall survival median. Whereas the Nivo alone was 6.9 months of PFS and just under 37 months of OS at median level. So these numbers illustrate the impressive curative fraction for patients treated with the combination Nivo and Ipi. But we know that treatment's very toxic, and so Checkmate 511 was designed, where the doublet Nivo and Ipi combination was compared in 2 dosing regimens. So one dosing regimen was the standard dose. The other regimen was a quote-unquote flip dose or renal dosing regimen, where the Nivo was 3 mg per kg and Ipi was 1 mg per kg. In this trial, the median PFS and OS was not statistically different at first publication so far, but however, long-term overall survival follow-up is pending. But the main difference is that the treatment combination of the doublet led to significantly less grade 3 to 5 events, with only 34% of patients in the Ipi-1 group versus 50% of patients in the Ipi-3 group having grade 3 to 5 events, which was statistically significant. Treatment discontinuation was also less frequent in the Ipi-1 group, with only 24% of discontinuations versus 33% discontinuing to AEs. So this just kind of sets up in the discussion our first abstract. So the first abstract to discuss was from the ASCO plenary last year, called the DREAM-seq trial. This trial compared the sequencing of immunotherapy and targeted therapies for BRAF mutant melanomas. And so in the top sequence, Ipi and Nivo was given, followed by BRAF and MEK on disease progression versus BRAF and MEK inhibition on the first treatment, and then Nivo and Ipi at progression. Patients were stratified by ECOG and LDH. The demographics were similar between the patients. Primarily, most of the patients were M1C disease. My notes. Objective response rates were similar for immunotherapy and targeted therapy in the first line. However, in second line, immunotherapy response rate was numerically lower in the first line at only 30%. So this also translated to a progression-free survival difference. Initially, you see that PFS benefit of targeted therapy over immunotherapy, until about 9 months, at which time the curves cross and support the improved median PFS of 1 and 2 years for immunotherapy. 19% for the targeted therapy first versus 42% progression-free at 24 months for the immunotherapy first. This also translates into a statistically significant overall survival benefit for the doublet immunotherapy, followed by targeted BRAF/MEK inhibition, with nearly 20% difference between the two when compared at 2 years, with 72% versus 52% survival rates. Duration of response was also superior for the checkpoint inhibition, with median targeted therapy duration of only 12.7 months, and the median duration of response for the combination therapy not yet reached at this time point of the presentation. And so in summary, for this abstract, unless ineligible for checkpoint inhibition should be the first-line therapy of choice for all patients with BRAF mutant advanced or metastatic melanoma. And an impressive 20% survival difference compels us, for this treatment option when you look at the 2-year survival rates. However, there are still some patients in the first 10 months of therapy with checkpoint who experience, relatively rapid progression, and that the target therapy could have benefited their widely metastatic disease at that point. Moving on to the next abstract. So the new kid on the block is the drug relatlimab, which is a LAG-3 inhibitor, and nivolumab. And this is in the Relativity 047. This is the updated data from the March ASCO plenary of this year, which is an update to the NAJM article by Dr. Taubey. So in this trial, patients were randomized to nivo plus ipi versus nivo alone, randomized 1-to-1, and stratified by LAG-3, PD-L1, BRAF status, and AGCC stage version 8. On demographics, nothing concerning, equally split. I'm looking at the LAG-3 expression. The whole population, about 75% of patients had greater than 1% LAG-3 expression. The primary endpoint was PFS for this trial. The combination with relatlimab had improved PFS of 10.2 months versus only 4.6 for the singlet arm. Hazard ratio of 0.78, and that was statistically significant. Looking at the forest plot for PFS across stratification factors, PD-L1's expression of less than 1% actually did lead to improved PFS compared to those with PD-L1% of greater than 1 favoring the combination arm. LAG-3 expression was not at least statistically significant, although it looks like it was trending that way. The secondary endpoint was overall survival. Overall survival data at this point of follow-up shows a non-statistically significant longer OS and median follow-up of 19.3 months for the combination with relatlimab. The forest plot for overall survival, nothing was statistically significant. Everything crosses 1, at least at this point. Looking at the objective response rate was 43% in the combination versus 32% in the nivo arm. Complete response rate was ever so slightly higher, probably equal, for the doublet arm. Disease control rate was not drastically dissimilar as well. The side effects is one of the other things that's important. We know, as we just talked about, that the nivo and ipi combination is very toxic. However, this combination was less toxic if you think back to those numbers. So the nivo alone was only 11.1% of grade 3 to 4 events versus 21.1% for the nivo and ipi. And discontinuation, there's no treatment-related deaths. The most common side effects were similar to what we've seen with other immunotherapies, with rash, diarrhea, hyperthyroidism, hepatitis, adrenal insufficiency, I don't think I put it on this slide, but one of the things that's interesting is they actually note how many patients had vitiligo in the paper, which I think is something that people are starting to recognize a little bit more. So in summary, relatlimab adds additional PFS benefit to nivo without significant additive toxicity. OS is not yet shown to be superior to combination therapy. However, it is trending to improved OS. And so we'll see if it ekes out a superiority in survival. So maybe next month at ESMO or ASCO next year, we'll see if there's any new updates. Notably, it was not compared to the standard of care regimen of Nivo and Ipi for those with good PFS. All the patients in this trial had good PFS, so it's one thing to keep in mind that they did not compare it to Nivo and Ipi, which is the standard of care. This is a chart I really like that Dr. Dowd presented in his discussion, and it kind of gives dots for each of the trials, comparing side effects and comparing the PFS. And so if you look, Checkmate 067, the top right red dot is the best at PFS, but also the worst at side effects, whereas relatlimab and then the flip dose Nivo Ipi seem to show a little bit better balance of side effects and progression-free survival. But again, this is just progression-free survival chart. We really need that overall survival chart. So hopefully we'll be able to update this graph with overall survival soon. Okay, I guess I did talk quick enough. So the other interesting abstract that I think is important to know about is the adjuvant checkpoint inhibition for stage 2B or 2C melanomas. This is the phase 3 Keynote 716. This was initially presented by Dr. Luke at ESMO in Paris last year, but then it was again updated by Dr. Long here at ASCO this year. And so this study design was taking patients with stage 2 resected disease, negative sentinel lymph nodes, so 2B and 2C means T stage of 3B, 4A, and 4B. They were randomized to Keytruda versus placebo, and they were followed up for recurrence. And obviously they were unblinded and they were allowed to get pembrolizumab if they progressed. Primary endpoint was recurrence-free survival, secondary disease, distant metastatic-free survival, and overall survival. Baseline characteristics, pretty equal. You can see though, look, this is different this is an adjuvant study, so the ECOG is almost all 0. It's one thing just to point out because these patients are very healthy coming into the trial. Recurrence-free survival, so this is at interval analysis 3. There's been 95 events in the pembro arm versus 140-ish in the placebo arm for 24-month survival rate of 81 versus 73. Median months was 37 versus not yet reached. Distant metastasis-free survival, 24 months, only about a 6% difference, and 4% difference at 12 months. It is statistically significant, though. They calculate probably largely due to these large numbers they were able to recruit. Summary adverse events, treatment-related, were 83%, 17% had grade 3 in the treatment arm, 16 discontinued. Importantly, 0 patients had deaths from this adjuvant treatment. And then looking at these grade 3 side effects, diarrhea, again, something we're used to seeing, rash. So in summary, this treatment is now FDA approved for adjuvant therapy in stage 2B and 2C melanomas. If and when an overall survival benefit is confirmed, then treatment should have a high recommendation in this population of patients to confirm treatment improves survival. However, given side effects from immunotherapy can persist lifelong, it's still an individual decision and you have to counsel patients, and in some patients the benefits may be outweighed by the risks. So, and then, I think I'll leave this one out, or do we have time? Okay, so I guess I was talking really fast. So the survival data for the Prado. So this is one of the most exciting abstracts, I think. So this is from Dr. Blanc and Netherlands Cancer Institute at ASCO this year. This was this phase 2 study of neoadjuvant Ipi and Nivo in clinical stage 3 melanomas. So the thought is that in the adjuvant setting, there's little tumor bulk for the for the antigen-presenting cells to, be able to be activated from the immunotherapy, the T cells be activated from the immunotherapy. And so giving it in the neoadjuvant setting where there's lots of tumor bulk might be a benefit in generating those T cell clones that are going to respond to the melanoma. This is the Opacin Neo trial, the updated results. And so what they saw was that in the anti-PD-1 only arm, pathologic non-response was seen in 66% of patients, whereas in the combination Nivo and Ipi arm, only 25% had a pathologic non-response. And this is how they define this. So after they gave the Nivo and Ipi, then they looked at the pathology, and path CR was 0% viable tumor, path near CR was up to 10% viable tumor, path partial response was 10 to 50% viable tumor, and path non-response is still greater than 50% viable tumor. And so this is kind of what set the stage. These were earlier phase 2 trials. And so the Prado design was stage 3B, 3C. They were given 1 mg per kg of Ipi, 3 mg per kg of Nivo for 2 cycles, 3 weeks apart, after an indexed node had a marker placed, and then they underwent resection at week 6. If they had a path CR or near path CR, they did not undergo therapeutic lymph node dissection. If they had a partial response, they did still go under therapeutic lymph node dissection, but they didn't have any more adjuvant therapy. If they had non-response, they were able to go, or they had to go on to therapeutic lymph node dissection, and were allowed to get more adjuvant therapy with either BRAF or checkpoint inhibition. And so the primary objective was to confirm the pathologic response and see how many patients had a major pathologic response. Based on characteristics, so relatively young population, predominantly male, ECOG 0, almost everybody, and these are all European institutions. I think they're all in the Netherlands. Netherlands Cancer Institute is a predominant enroller. And most of the patients only had 1 node, and very few had greater than 3 nodes to be enrolled in this trial. 30% had a grade 3 to 4 event with the treatment. Relapse-free survival for the overall population was 85% versus distant metastasis was 89%. For the major pathologic response, these are excellent numbers. It's making melanoma look like breast cancer maybe. And so the relapse-free survival was 93% at 2 years, and 98% distant metastasis-free survival at 24 for those 60 patients that had a major pathologic response. Then adding in the non-responders, pathologic non-response in the red line, they didn't do as well. They had 81% at 12 months and 71% at 24 months. And then the near response that was actually did the worst at 73% at 1 year and 64% at 2 years. So this is the chart that gives those numbers. So the complete responders did the best. Partial responders actually did worse than the no response. And they estimate that this is likely due to the addition of further adjuvant therapy for the non-responders. Yep, and so that's the end of these abstracts. So hopefully these 4 abstracts were good. If anybody wants another melanoma abstract, the other one I didn't present is desmoplastic melanoma neoadjuvant Keytruda, which is a SWOG study, and that's another good one to look at if you need another melanoma abstract.